Good evening, everybody. I'm Dr. Rick Lehman in St. Louis, and this is In Your Corner with CORA. Today's date is August 12th, 2020. Still in the midst of the COVID disaster, and hopefully we'll get out of this at some point. I'm going to ask everybody to introduce themselves, starting with Katie. You're up.
Hi there, my name is Katie Stevens, and I'm a physical therapist at Tennessee Orthopedics Clinics in Knoxville, Tennessee.
Thanks, Katie. I'm Dr. Fallon Malak. I'm an orthopedic surgeon in private practice here in St. Louis, specializing in hip and knee replacements.
Ash, 314.
Hi, I'm Ashley McFadden. I'm at our O'Fallon Clinic. I'm clinic manager here. So O'Fallon, Missouri. Nice to be here with you guys.
Dr. Hamilton.
Hey there, I'm Hunter Hamilton. I'm at Tennessee Orthopedic Clinic as well. I'm an orthopedic surgeon, also specializing in hip and knee reconstruction.
That's awesome. So let's just jump right in. Tonight we're talking about total hip replacements, and we're talking about the difference between anterior and posterior approaches, anterior and lateral approaches, which we kind of bundle a little bit. And certainly there's been a change since I was a resident many, many years ago, where we only went posterior. All of our approaches were posterior, and things have certainly migrated a little bit. And there are still people very, very strongly suggesting a posterior approach. We're going to talk about that a little bit tonight. So to kind of jump in, Dr. Hamilton, could you describe the anterior approach and the lateral approach of the hip, talking primarily about the approach and then talking about the neurovascular pitfalls, structures you have to be careful, and what the anatomic approach of the hip is?
Sure. So I primarily only use direct anterior. I don't do lateral, but I can comment on it a little bit. But from a direct anterior approach, the patient is supine. Our incision is located just distal and lateral to the anterior superior iliac spine, almost in line with the femur. You kind of can palpate the belly, the tensor fascia, and you make your incision centered over that. When you're coming down, at least for me, I was always taught to incise through the tensor fascia to try to avoid the lateral femoral cutaneous nerve to prevent dysesthesias or damage to that. And you elevate the fascia medially and the muscle belly laterally, and then you kind of come into this plane between sartorius and the tensor fasciolata, and then deep, your plane is the rectus femoris as well as the gluteus medius, and you're kind of at an intermuscular and internervous plane there. So medially, you have structures innervated by the femoral nerve. Laterally, you have structures innervated by the superior gluteal nerve. The biggest, neurovascular structure you want to try to protect would be the lateral femoral cutaneous, unless you get too medial, in which case you run into the femoral neurovascular bundles at that point. And from
you don't worry too much about the femoral artery. That's not an issue for you.
I mean, if you're in the wrong spot, it should be, but it's not one that if you know your landmarks and you feel comfortable where you are, that should be relatively safe.
Great. Thank you. Dr. Malak, why don't you start off by describing the posterior approach of the hip, and again, the neurovascular structures, how you approach the hip, and kind of what keeps you up at night, what makes you worried about getting into the wrong plane?
Well, thanks, Rick. Certainly, hip replacement has become one of the great operations in orthopedic surgery. Very dependable, very reliable. The technology of the actual components has evolved over the last 25 years, so we don't really have as many issues as we used to with the components, their longevity, their failure. And so now we're looking, as you talked about, of different ways to skin the cat. What's the best way to get into the hip, replace the hip, and do as little damage as possible? You heard about the anterior approach. That's coming back into vogue. People tried it in the 80s, and Rick and I remember back when we were at the Shriners Hospital together, we used to do it on kids, used to do anterior approaches on kids. And so it's been around for a long time, and it is a good approach because it's you can go intramuscular between muscles, between nerves, and find a good plane. The reason it fell out of favor is that it can be complicated. You can get lost in the front of the hip very easily, whereas when we do posterior approaches that have been done for eons, it's a very simple approach. the patient is put in a lateral position, and you go that way. And then as you get to the hip, you get right onto the bone and just work your way around to the back of the hip and dissect through the gluteus maximus. And then what we do is we take down some of the external rotators. Those are the small muscles that rotate the hip. And then we take down, open the hip capsule. This has evolved over the years. It used to be a much more extensile dissection, but now we've gotten better at making a much smaller incision. So there's sort of mini posterior incisions now where we take less muscle, less capsule. But the secret, again, is to get good exposure so that you can do the main job of a hip replacement, is putting in that new hip so that it's in the perfect, proper position, and it's going to last as long as possible. And then after you put it in is to repair all the damage you did getting into the hip. And that's really what surgeons have figured out how to do better, is to get in and get out with as little damage to secondary structures. The main secondary structure we're worried about in hip replacements is the sciatic nerve. And so often or rarely do we even see the sciatic nerve. We just know where it is and we stay away from it. But that's the main vascular structure, nervous structure. There's not many vascular structures in the back of the hip that we worry about. There's some small perforating the superior and inferior gluteal artery, but we stay away from those as well. And so it's a very safe approach, and it gives us a lot of ability to put in different kind of hips and components.
Thank you. That was excellent. Both you guys, that was very concise. And so it sounds like really the issues are the femoral neurovascular structures and sciatic nerve. And it sounds like you guys are not really too terribly concerned about neurovascular damage. Probably both you guys have done so many joints that it's probably really not a factor. Certainly it's something that you're going to see on your board exam, because that's the questions they're going to ask you. Dr. Hamilton, and I think this is a very important question, what are the indications for an anterior approach? And if you could just speak for a minute, what are the indications for a lateral approach? And are there any indications specifically where you would say a posterior approach to the hip is absolutely not indicated and you should either go anterior, in your case, or anterior lateral?
That's a really good question. I was trained for posterior lateral and then direct anterior approach, and I think they're both excellent approaches. I don't know if there's a particular indication for an anterior approach. I think really the better question is, what is the contraindication to the direct anterior approach? And we might go into that a little later, but I think ultimately it's the approach that Dr. Malak said, that allows you to put the components in the most confident manner that you can do it and put them in the appropriate position. Anterior approach can be helpful if there's any type of a hip that maybe would be hard to dislocate because of morphology or dysplasia or something along those lines, where you can do an inside two cut more easily and get the femoral head out more easily than having to potentially dislocate the hip or have difficulty dislocating a hip from a posterior aspect. I think overall, though, I'd say I have in practice, I've yet to do a primary approach, primary posterior approach for a hip, rather. I certainly do my revisions posteriorly still, though. I find that you are afforded a greater exposure if you need to extend proximally and distally to address multiple issues from a posterior aspect. And so I do not do revisions anteriorly, but certainly there are guys that do.
So just to kind of play off that a little bit, somebody comes in, they've got CDH, long-term hip dysplasia, your prototypical flat acetabulum, looks terrible, leg length discrepancy. You're pretty comfortable going anterior in terms of a primary total, correcting the leg length, etc.
I am. The hardest part is finding the hip center in that situation. And I use technology for my primary hips, and so I'm able to do some computer mapping and planning beforehand to help establish that. So it helps a little bit, I think, maybe to make sure you're in the right plane, in the right area of the pelvis. But you certainly can extend if I felt like I was going to need to do a femoral osteotomy or something along those lines to shorten the femur, I would certainly think twice about going to an anterior approach. I'd probably choose a posterior approach, but I have not encountered that in private practice.
Thank you. And Dr. Malek, I'll ask you the same question kind of on the backside a little bit. What are the indications for a posterior approach? And are there any patients that you would say, absolutely, you got to go posterior? And we heard a little bit of this, maybe a revision, where an anterior approach, just you'd say, hey, that's just not indicated.
Yes, I'm a hip surgeon that does all posterior or posterior lateral approaches. So for me, the indications, if someone needs a hip or a revision hip, I'm going to do it the same approach every time. Interestingly, I think one of the things about hip surgery is that the pelvis is a very complicated three-dimensional structure. And I think what surgeons are finding is you have to get comfortable in understanding that three-dimensional architecture. And if you're going to it from the front all the time, it's much easier to do what you're comfortable with and oriented three-dimensionally, posteriorly the same way. And one of the things we'll probably be talking about in the future more is robotic assisted surgery to help you understand that three-dimensional anatomy, so that I know anterior surgeons tend to use C-arm during surgery. Posterior surgeons don't. We sort of are seeing what we want to do and putting in the components without C-arm or robotic assistance. But that's sort of the next wave of the future, is to use that technology to make our components even more dependably positioned. And so for me, as a posterior surgeon, I can do primary surgery or revision surgery without a problem. But I could see that in the future, there'll be newer technology that will help us do even better jobs.
And you think with, everyone's talking about minimally invasive total hips, minimally invasive total knees. Do you think robotics are going to decrease the size of your capsulotomy, or do you think it's going to decrease the incision size, i.e. the post-op rehab time?
It certainly might. I know our incisions have shrunk dramatically from when we did them 10 and 15 years ago. If we look back at those, we do much less muscle dissection, much smaller capsulotomies. And so even without the robotics, we can do things with less damage to those normal structures. And so I could see the future with robotics. It might augment that even more, so that we can do less damage while we put in a hip.
I'm currently using robotic assisted for all my primaries. I use it for my cup and my anterior hips, and then I use it for my knees. And I find that, for your hip, it does allow for maybe a little bit of a smaller capsulectomy or exposure, because you have to trust the robot. But it allows you to kind of, once the arrays are on the pelvis, and the robot knows where the pelvis is in space, you don't need the visualization as much. You certainly want to see where you're putting the components. And with respect to the knee, my incision from when I started training, which, I've only been out in practice now for a little over a year, hasn't changed when I went to robotic knees, but I think my soft tissue dissection within the wound has certainly changed. I'm doing less releases. You can make, degree here, degree there, change with the orientation of your cuts from a knee standpoint that might allow you to prevent, stripping the proximal tibia and doing a complete release there. And I think that would be the minimally invasive aspect of it, not so much the skin incision.
Yeah. If I might ask you a question, Dr. Hamilton, I know some of my partners, they have more trouble when they're doing anterior hips on obese patients. And I'm wondering if you might talk about that a little. Posterior approaches, obesity is not a problem. Things fall away. Sure. I know my partners, though, seem to have, that might be the relative contraindication for them, is on heavy patients. Hard to get the hip up out of the wound so that they can work on it.
Absolutely. That was when he had asked me what the indication for an anterior hip. My comment was more, what's the contraindication? My cutoff would be about a BMI of 45 for an anterior hip, and our group cutoff is around 40. So I have to get special permission to operate on somebody over that anyways. I think the biggest concern is how mobile that soft tissue is. If you're able to tape the pannus out of the way, then the distance from the anterior aspect of the thigh to the anterior femur is sometimes be much smaller than from the lateral aspect of the hip to the hip joint, depending on where their fat and subcutaneous tissue is. But it is certainly, I think from an obesity standpoint, my biggest concern is wound healing as that pannus lays over the wound and you start running into wound issues from an anterior approach. And so depending on the way their soft tissue is distributed, that would be a reason for me to do a posterior approach in somebody potentially.
Mm-hmm. That's excellent. All right, let's switch gears just a little bit. Katie, let's talk a little bit about your post-op regimen as a therapist, and let's start. The patient is in recovery. Kind of walk us through soup to nuts. And again, you guys have been great, so jump in if you feel like you've got something to add. But Katie, you're up.
Yeah, I think one of the biggest things I find is just sort of managing expectations for the patients on the front end, especially as it relates to the total hips. I find that a lot of our patients kind of come in with this notion that the hips are going to be pretty easy of the total joints. And so they come in expecting 2 weeks out from surgery to be running around and back into doing everything. And so a lot of it is just kind of an education on the front end, explaining the overall rehab process. You know, I certainly with the anterior hips, I try not to get too aggressive with hip flexion, strengthening right off the bat. I do find that tends to aggravate patients, and once you kind of set that hip flexor off and you get that pain going, it's hard to kind of reel that back in. So I definitely go a little less aggressive on that hip flexion to start with there. But overall strengthening, they seem to tolerate overall strengthening a little bit better and quicker in general. And then with you know, a lot of focus on gait. And how patients are walking, because most of the time when they're getting the hips done, they've been dealing with this for a long time, and it's re-educating, relearning how to do things that they hadn't done before. I find that uneven surfaces and stability tends to be a big fear for patients afterwards, so we do a lot of focus on that, and that seems to. But overall rehab, they do really well. I mean, generally 3 or 4 weeks out, they're in pretty good shape.
So initially, when do you get the patient up? The patient's in recovery. When's the first time they get to stand on their brand new $5,000 hip?
Oh, they do it in the hospital. I mean, a day of surgery. So we generally see them 2 or 3 days post-op in our outpatient clinic. But they're up same day, and oftentimes, you know, they're going home the same day a lot of times, and that's very common. They get them up. They get them up and down stairs and in and out of cars and out of bathtubs, show them how to do all that stuff so that they're ready to go home.
That's excellent.
I would say in general here, Dr. Lehman, we're seeing them about 2 to 3 weeks post-op, because most of the patients we see are having home health 2 to 3 times a week for 2 to 3 weeks. And in general, they're working more on safe transfers, like getting in and out of bed, getting up from their chair, getting in and out of their house, getting to their car. And once they're safe with all the transfers and car transfers, then they're coming to see us in the outpatient clinic. So when we see them in the clinic, they're already weaning from their walker to their cane. And so we're working on initially the pain and the range of motion. And then by the time they get to us, honestly, we're already, okay, what's your goal? What do you want to get back to? What's your prior level of function? Because they're progressing so quickly nowadays.
So let's expand upon that just a little bit, Ash.
Okay.
What are the precautions? Someone comes in 2 weeks, they had an anterior approach, they had a lateral approach, or they had a posterior approach. What is Dr. Malock and Dr. Hamilton telling you that these patients shouldn't do for potential complications, i.e. dislocations, etc.? And is there a difference between the anterior and the posterior?
Okay, and Katie, you can chime in at the end of this too, because the majority that we see in the clinic here are posterior lateral approach. So first I'll go through the precautions with those patients. So number one, the patient is not flexing their hip past 90 degrees. So we have to really be cautious of that when they're sitting in a chair or when they're dressing. So when they're putting their shoes and socks on, that they're not raising their hip past 90 degrees. Number two would be not crossing midline. So we do not want to adduct the hip. So they have to be cautious of that when they're laying in bed, that they're not laying on their side. And if they are, they have a pillow in between their knees. And then lastly, avoiding hip internal rotation. And so that is mostly, they need to be aware of that when they're changing direction, so that they're picking up their feet and they're not pivoting and causing that internal rotation. So those would be the main precautions that we see in the clinic for posterior lateral approach. And that's in place anywhere from a month to, the longest I hear would be 12 weeks. But again, nowadays, the doctors are weaning the precautions earlier and earlier. We do see an occasional anterior approach, and the only precautions that we give from our physicians in the area would be an occasional don't lay on their stomach at first, but avoiding the hip extension. We, however, just had one we started this week and they didn't have any precautions at all. So the precautions are, they're weaning them earlier and earlier, I would say, because the patients are progressing quicker and the procedures are now so much less invasive.
Hey, did you have anything to add?
Yeah, I would agree with what Ashley said. I mean, I think even I've been practicing with tennis orthopedic clinics for 11 years now, and even in the last 4 or 5 years, I think you've really seen a lessening of the overall hip precautions for both the posterior and the anterior, and we see a good mix of both. We have physicians that do both, and a variation in what the overall precautions are there. With the anteriors, like Ashley said, sometimes there's no precautions at all, and for some of the doctors, it's really just more of like, don't aggressively stretch into extension, but it's not necessarily a major issue. It's more just don't get aggressive with it. With the posteriors, most of our docs are releasing them in that 3 to 4 week range from the hip precautions that Ashley was talking about. And they do really well, both with the anteriors and the posteriors overall. And it has really sped up really within even the last 4 or 5 years. I've just seen a tremendous difference in how quickly patients are recovering.
Thank you. You guys have been awesome, and I really appreciate it. CORA appreciates it. And I want to thank everybody. This is very informative. I think there's a real comfort level after hearing this in terms of whether your surgeon's going posterior, anterior, but I think the take-home message from both you guys is, hey, you need someone who's doing a lot of total joints, and you need someone who's very comfortable and who's well-trained. And as long as it's like getting your refrigerator fixed, if the guy fixes refrigerators and cars and roofs, it's probably not your guy. If all he fixes the refrigerators, he probably is your guy. And so I think experience, like in most things, goes a long way. So gentlemen and ladies, thank you very, very much. And we'll do it again. Thank you.